KDIGO has released guidelines for the management of membranous nephropathy in adults and in children. Okay, so what does KDIGO 2012 guidelines say? First thing that is important is we have to do appropriate investigation to rule out secondary, like for lung carcinoma or for colon carcinoma, any appropriate investigation has to be done. Then initial therapy, for whom will we give immunosuppression? If urinary protein excretion persistently exceeds 4 gram per day and it remains over 50% of the baseline value and it does not show progressive decline with all the therapy for 6 months. So if you go back, this is the group they are talking about, where proteinuria is more than 4, less than 8, but after giving 6 months of treatment with AC inhibitors and statins and other antihypertensive, proteinuria has not reduced even to 50% of the baseline, or proteinuria is persistently above 4 gram. Okay. Second thing is, if the patient has severe, disabling or life-threatening symptoms related to nephrotic syndrome. This I told you, most commonly it means thrombosis. It can be venous thrombosis, rarely arterial thrombosis. So if this is occurring, then we have to directly go ahead and start immunosuppression. Again, if serum creatinine is risen by 30% within 6 to 12 months from the time of diagnosis, but it is not less than 25 to 30. See, because if GFR is less than 25 to 30 already when patient comes for review, then there is no point in putting immunosuppression, because immunosuppression is going to damage the kidney more, right? So, if serum creatinine has increased by 30%, like last year it was 1, this year it is 1.3, then also we should consider adding immunosuppression for these patients. Now, if creatinine is more than 3.5 or if GFR is less than 30, do not start the patient on immunosuppression. Till now we learnt in whom we should give. Now we are learning in whom we should not give. Okay. Prophylactic anticoagulation has to be given when albumin is less than 2.5. Okay. Otherwise, this is done to prevent the hypercoagulability. Now coming to remission. What is the definition of remission? This is adapted from 2012 KDIGO guidelines. It is classified into two. One is complete remission, other one is partial remission. Okay. Now, complete remission is if urinary protein excretion is less than 0.3 gram per day or 300 milligram per day. Okay. This has to be confirmed by doing two values at least 1 week apart. That is, today you do, if today is Monday, then again you do next Monday. Okay. And a normal serum creatinine. So, the serum creatinine should be normal and proteinuria should be less than 300 milligram per day. This is complete remission. Partial remission is when proteinuria is less than 3.5 gram per day and you see that there is more than 50% reduction from the peak value. Okay, it might have not reached the normal range of 150 or 300, but it is less than 3.5 gram and 50% reduction from the time of starting treatment is noticed. Okay, this also should be taken two values 1 week apart, and then we have to also see that stable serum creatinine is there and normalization of serum albumin. Okay, so serum albumin normalizing meaning proteinuria has reduced. Okay, so all these are the factors that we have to include while defining complete remission and partial remission in membranous nephropathy. Now, coming to the Ponticelli regimen and the modified Ponticelli regimen, if we are deciding to give immunosuppression, this is the best treatment available. So, in the Ponticelli regimen, it was said that IV methylprednisolone has to be given 1 gram, which is followed by oral methylprednisolone 0.5 milligram per kg per day. So, this is Ponticelli. So, what did modified Ponticelli say is the oral methylprednisolone had become oral prednisolone. Okay, same prednisolone, which is given for 0.5 mg per kg per day for 27 days. So, in a month, if this is 6 months treatment, in first month, second, third, 4, 5 and 6. So, month 1, month 3 and month 5, you give this, there are 30 days, right? 1, 2, 3, 4 and here I'll write 30. So, this 3 days you give pulse steroid, followed by these days you give oral steroid, right? and in 2, 4 and 6 months is when you are going to give alkylating agents. If it is Ponticelli, then chlorambucil or cyclophosphamide. There was an option to use chlorambucil or cyclophosphamide, but cyclophosphamide was more preferred. In modified Ponticelli, it is cyclophosphamide. So these are the two important difference between Ponticelli and modified Ponticelli. That is, oral prednisolone was used and cyclophosphamide was used. Okay, so here cyclophosphamide is used. It is generally given at the dose of 2 mg per kg. This is done for 30 days. So this keeps alternating, and it's 6 months treatment is completed. Now, what are the risks and benefits of giving Ponticelli regimen, which has an alkylating agent? Okay. Now, there is enhanced risk of opportunistic infection. There is reactivation of viral hepatitis, alopecia, gonadal damage like aspermatogenesis and ovulation failure. So, if you are starting this treatment for a young person, then it is better to suggest all these regimens. Okay. Then hemorrhagic cystitis with cyclophosphamide only. Neoplasms, if it is there, cyclophosphamide can worsen it. So, in neoplasms, try to avoid this. Then transitional cell carcinoma of the bladder, ureter and pelvis and toxic hepatitis. So, all these are the risks. Benefit is it is going to prevent CKD, ESRD, complications of nephrotic syndrome, and hence it prolongs life and also quality of life. So, basically the progression to ESRD is prevented by giving this regimen. Now, what are the contraindications for Ponticelli? So, first is untreated infection, maybe HIV or hepatitis. Any untreated infection is contraindicated. Next is neoplasia, because it has malignant potential. So, lung, skin, breast, colon, anywhere. If there is urinary retention and there is inability to comply with monitoring, that is, we have to call the patient to monitor WBC count, which can get suppressed. So, if this is not happening, then it is better not to start. Okay. If there is pre-existing leukopenia and if creatinine is more than 3.5. So, these are the contraindications for starting Ponticelli regimen. Creatinine more than 3.5 means already the kidney has gone into CKD and giving immunosuppression might not help. Now, that is about Ponticelli and modified Ponticelli. Now, what are the CNI based regimens? Okay. Now, coming to cyclosporin. Cyclosporin is given at the dosage of 3.5 to 5 mg per kg per day, which is given orally in 2 equally divided doses 12 hours apart. That is, generally it will be given at 8 am and 8 pm. This has to be given along with low dose steroid, that is 0.15 mg per kg per day for 6 months. And they are suggesting to start at lower range of CNI and gradually increase if there is no nephrotoxicity. Tacrolimus is started at the dose of 0.05 to 0.075 mg per kg per day. Okay, and it is given orally in 2 divided doses, same 12 hours apart. And this, once given with tacrolimus, it is given without steroid. Okay, with cyclosporin, when you are giving, it is important to give with steroid. Tacrolimus, that is sufficient to give without steroid, and additional steroid can much worsen the risk of diabetes. So, it is generally given without steroid. Okay, and it is generally suggested to start at a low range and then increase gradually to avoid nephrotoxicity. Now, that was about KDIGO 2012. Now, KDIGO glomerulonephritis guidelines are not revised since 2012. So, in 2020, a public draft guideline was released, as in it was approximately a 400 to 500 pages booklet that was released, and it was kept for public opinion to make any necessary changes. The final guideline is not yet out, but then this guideline gave so many, this public draft, which is just a sample guideline, gave so many important points. So, here I have picked it up and I have used it here. As of now, this public draft guideline is being removed from the KDIGO website. It is not available in the website, but I have removed this section and I am using this because it gives a nice outlook and it also incorporates the recent therapy with rituximab, because from 2012, after 2012, a lot of trials have come which supports use of rituximab primarily. Okay, so I discussed there are 3 regimens, right? First is the modified Ponticelli, second one is CNI based regimen, that is cyclosporine plus steroid. Third one is rituximab. So generally any patient comes in the olden days, modified Ponticelli would be the first treatment regimen that is initiated. But then after finding out there are trials which I will be dealing with in the section of trials which prove that rituximab is equally good. It is doing as good as modified Ponticelli. Then it was challenged, the notion of using only modified Ponticelli was challenged. So think what are the problems modified Ponticelli can cause. We are giving cyclophosphamide, right? So it can affect the fertility of the patient and it can cause malignancy risk. So if a patient is coming, it is a young lady or a young male, instead of affecting the fertility by giving cyclophosphamide, we can try rituximab in those patients. Similarly, another group of patients for whom rituximab will work is if they have failed other immunosuppressive therapy. Okay, so rituximab currently is being used very much as first line therapy, as good as modified Ponticelli. Generally, CNI is not used as first line therapy in some condition where both these things cannot be used, like patient has some infection or severe immunosuppression already. When these two regimens cannot be used, that is Ritux or modified Ponticelli cannot be used, in that situation we go ahead and use CNI with steroid. Okay, so let us see what this public draft guideline says. So they tell when the patient of membranous nephropathy comes, we have to screen for secondaries, that is chest x-ray to rule out sarcoidosis, history of drug use like NSAID, gold, penicillamine, presence of anti-nuclear antibody to diagnose SLE, full history of any systemic diseases, thyroid diseases, and physical examination of skin or joints to see for autoimmune disease. HBV, HCV, HIV and treponema, all these are infections that can cause membranous nephropathy. Ultrasound of the kidneys and screening for malignancy, age appropriate screening for lung carcinoma or GI carcinoma has to be made. Now, they classified again the population into 4 risk. Okay, first is low risk, that is remember mostly it is based on 1, 2 or 3 criteria, that is what is the GFR of the patient, how severe is the proteinuria. Some people use albumin also. So if the patient has GFR, proteinuria and albumin, right? So if the patient has normal GFR, proteinuria less than 3.5 and serum albumin more than 3, then this is considered as low risk group. Moderate risk group, okay, that means normal GFR, proteinuria which is more than 4 gram per day, or there is no reduction less than 50% for 6 months of giving the therapy. Okay, and in this group additionally we have to see PLA2R receptor antibody level. Okay, if PLA2R receptor antibody level is less than 50 and the proteinuria is generally mild low molecular weight where selectivity index is low, okay, and urinary IgG is less than 250, that means there is no severe tubular damage, there is no tubular proteinuria. Okay, so all this will indicate that they are in moderate risk group. Now high risk group becomes if GFR is less than 60, proteinuria is more than 8 gram per day for 6 months, right? And here PLA2R receptor antibody in the high risk group is more than 150. Here in the moderate or the medium risk group it was less than 50. In the high risk group it is more than 150 and urinary IgG is high, selectivity index is also high. Okay. Now coming to very high risk group, this is where there is life-threatening nephrotic syndrome, rapid deterioration of kidney function that is not otherwise explained, and high low molecular weight proteinuria in 2 urine samples collected with intervals of 6 to 12 months. So the IgG levels or low molecular weight proteinuria is very, very high. So very high risk is when there is severe complications of nephrotic syndrome. Other than that, based on these parameters, it is divided into low, medium and high risk. Okay. So apart from what we discussed previously, here you can see that the levels of PLA2R antibody is important in classifying these patients. Okay. Now, as patient comes, first we do risk evaluation. Okay, that is what we saw previously. So if it is low risk group, we wait and watch. If it is moderate risk group, we can give rituximab or CNI. That is, it is not a severe disease. If it is in this moderate risk group, we can give rituximab or CNI. Okay. Now, if it is high risk group, another addition, that is modified Ponticelli, also gets added because it's a very, very powerful medication regimen. Generally, it is used only for high risk group. Okay, and very high risk, that is the last group, can use cyclophosphamide alone because they require intense immunosuppression. Now, once we start, how do we monitor? So, at 0 months, you start either rituximab, CNI plus steroid, or cyclophosphamide along with steroid, that is Ponticelli. Then at 3 months, you are going to remeasure the PLA2 receptor antibody. Okay. Now, if the PLA2 receptor antibody, there are 3 possibilities. It is absent, it has not changed, or it has increased. Okay. There is absent, that is it has decreased, or it is static, or it is increased. Now, if it is absent, then there is no requirement of any additional therapy. So, if you are given rituximab, don't give any additional dose. If you have given cyclophosphamide, you can taper the dose of cyclophosphamide. If it is CNI, you just continue the therapy. Now, PLA2 receptor is static. Then, if you are given rituximab, you give extra doses, you continue cyclophosphamide and continue CNI inhibitor. Now, if it is increased, that means you have to become very active. If you are given rituximab, give the patient extra doses of cyclophosphamide. Okay. If you have given cyclophosphamide, it is showing that the cyclophosphamide is not working, so give rituximab to the patient. Okay. And if you are giving CNI inhibitor, you can add either cyclophosphamide or rituximab. So, this is the decision you make at 3 months. Then again, you do the PLA2 receptor antibody at 6 months. Okay. Now, here also 3 possibilities. One is it is absent or low. That is, then what you will do? Again, same. You don't give any additional doses of rituximab. Cyclophosphamide you will taper, and you will consider stopping as per the treatment regimen, and CNI you will continue. Okay. If it is same level or moderately increased, then you give additional therapy like previously discussed, again with standard agents. If it is high titers or persistently increasing, we have to treat it as resistant disease. I will come to the treatment of resistant disease. Now, how do we manage relapse? Okay. So, first initial treatment is rituximab. If the patient has responded to rituximab in the relapse, you repeat rituximab. If we give CNI inhibitor, relapse, first line drug becomes rituximab with or without CNI inhibitor. Okay. Third is, if the patient is on cyclophosphamide and patient relapses, then you have to give patient another dose of modified Ponticelli can be given, which is maximum. If the patient previously has received 2, then it is better to go for rituximab. Now, what is treatment resistance? So, initial treatment, if it is with rituximab, then you see if the EGFR is stable, if the EGFR is decreasing. If the EGFR is stable and the patient is having resistant disease, can add CNI plus rituximab. If the EGFR is declining, then we do not have time and we cannot give CNI inhibitor, so we prefer cyclophosphamide. Even after that there is no response, cyclophosphamide. See, basically any disease that is resistant to one or the other drug, cyclophosphamide is given. Okay. So, first group is when you are giving rituximab, if the EGFR is declining, you consider giving cyclophosphamide. This table might be confusing, but I will just simplify it for you. If patient is resistant with rituximab, you give the patient cyclophosphamide. Okay. Second group, where we have given CNIs. Here there are 2 possibilities, that is EGFR is stable. In that situation, we have to give rituximab. Okay. If it is CNI, first is you give rituximab. Okay. Then if the GFR again is, if the kidney again is showing continuation signs of relapse, then you give cyclophosphamide. If the EGFR is declining, do not wait for this step, skip the step and directly go and give cyclophosphamide. Okay. Now, cyclophosphamide patient, if the EGFR is stable and patient has relapsed, try rituximab. Repeat cyclophosphamide can be tried. If EGFR is decreasing, try cyclophosphamide. So, it is important to know that when there is a resistant disease, cyclophosphamide is what is used most commonly, whether it is in the Rituximab group or cyclo group or cyclosporin group or the cyclophosphamide group. Now, about recurrence of this disease post transplantation. Okay, if it is a known PLA2R receptor antibody associated MN, then you measure the PLA2 receptor antibody. If it is positive, then there is high risk of recurrence. If it is negative, that means the antibodies are disappeared, the risk of recurrence is less than 10%. Okay, and if it is negative, if the serum is negative, we can do biopsy of the native kidney and stain it for PLA2 antigen. So if just PLA2 antigen is present and the antibody is absent, that means there is medium risk of recurrence, which is around 30%. Okay, even if the PLA2 antigen status is antibody status is unknown, then we have to follow this. Probably we'll do a biopsy and we'll stain the PLA2 in the kidney and see. Now, the recurrence rate depends on the evaluation of the causative antibodies. It may be higher after living-related donor transplantation, but the benefits of the living donation outweighs any harm caused by recurrence. Okay. In the peri and post-transplant period, every month monitor for proteinuria. Okay. And in patients with known PLA2R receptor antibody associated membranous nephropathy, measure this antibody every 1 to 3 months depending on the pre-transplant status. If it is increasing, then there is increased likelihood of recurrence, consider biopsy. If it is decreasing, low likelihood of recurrence, and only if indicated, kidney biopsy has to be performed. Now, treatment of recurrence. How do we treat? If at all recurrence occurs also, how do we treat this condition? Okay, we have to treat with AC inhibitor or ARB initially. Immunosuppressive therapy has to be monitored or optimized. See, generally the treatment for that is immunosuppression. Here patient is already receiving, so we have to optimize it. If it is less than 1 gram per day on all these things, then you see the patient at 1 to 3 months interval. If proteinuria is more than 1 gram per day despite all your efforts, then it is time to add another immunosuppression, which is rituximab. Rituximab 1 gram per day is given at day 1 and day 15. Okay. Now, coming to what is the anticoagulant therapy that is used in membranous nephropathy. So, if serum albumin is less than 2 with the bromocresol purple technique or less than 2.5 with bromocresol green technique. Okay. Now, if it is less than 2.5, then there is high risk of venous thromboembolic events. Assess the bleeding risk. If the bleeding risk for the patient is high, then give aspirin. If bleeding risk is low, then give warfarin with low molecular weight heparin. Okay. Now, if the serum albumin is more than 2.5, you see whether if serum albumin is more than 2.5 or less than 3.2. Okay. If it is more than 3.2, then there is no need for aspirin. If it is less than 3.2, again you see the risk of arterial thromboembolic event. Okay. That is, if there is high risk of arterial thromboembolic event, then you treat the patient with aspirin, and if there is low risk, there is no need for aspirin. So basically you have to assess the bleeding risk, the thrombotic risk when albumin falls less than 2.5, and then you have to start the treatment. We know that nephrotic syndrome, there is hypoalbuminemia because there is loss of albumin in the urine. Okay. So, the degree of hypoalbuminemia predicts what hypercoagulability is seen, because when the albumin is lost in urine, liver wants to synthesize more protein. So, it synthesizes all proteins, which involves coagulation factors. Okay. Plus, there are few anti-thrombotic agents which are lost in the urine. So, these two things coming together increases the clotting risk in patients. Okay.